Let's shift gears and talk about something that doesn't get nearly enough attention: Pseudobulbar Affect, or PBA. If you've ever had a patient who bursts into tears at the drop of a hat or starts laughing inappropriately during a serious conversation, you may have witnessed it firsthand. Pseudobulbar Affect is a neurologic condition. It causes sudden, exaggerated emotional responses that don't match the context. We're talking about episodes of uncontrollable laughing or crying that are often unrelated to how the person is actually feeling inside. It can be confusing to witness and downright distressing for the person experiencing it. Now, the key word in the name is pseudo, which means false, and bulbar, referring to the brainstem pathways that control emotion and expression. So we're looking at damage in the corticobulbar tracts of the brain. These tracts help regulate emotional expression. When they're damaged by a stroke, traumatic brain injury, MS, ALS, Alzheimer's, or Parkinson's disease, the brain loses some of that control. Let me paint the picture. You're caring for an older adult post-stroke. You're just walking in with lunch, nothing dramatic going on, and suddenly they start crying. Not just watery eyes, but full-on sobbing. You check their pain, their vitals, everything's normal. 5 minutes later, they're smiling and talking like nothing happened. That's classic PBA. This isn't the same as depression. Let me repeat that for the back row. Pseudobulbar affect is not depression, even though the crying might make you think so. Depression is a persistent mood state. PBA is a neurologic reflex, a brain misfire, if you will. And yes, they can coexist, but it's important not to mislabel one as the other. So, how does this affect our patients? Well, beyond the emotional roller coaster, it can lead to embarrassment, isolation, anxiety, and even depression over time. Patients might avoid social settings because they're afraid of crying in church or laughing at a funeral. The impact on quality of life is real, and as nurses, it's our job to notice it and advocate for treatment. Speaking of treatment, let's talk meds. One of the first FDA-approved treatments for PBA is a combo of dextromethorphan hydrobromide and quinidine sulfate. Now, dextromethorphan you probably know as a cough suppressant. It works on the brain's NMDA receptors. Quinidine slows its metabolism, helping it stick around longer and be more effective. Clinical studies have shown this combo helps reduce the frequency and severity of emotional outbursts in patients with ALS, MS, stroke, TBI, and dementia. Now, don't go throwing this med at everyone with a tear in their eye. It's essential to do a proper assessment. This condition should be recognized through patient history, observed behaviors, and ruling out mood disorders. You want to involve the neurologist or psychiatrist, and definitely keep the primary provider in the loop. What can nurses do? First, educate the family and patient. Let them know this is a neurologic condition, not a character flaw or emotional weakness. Second, watch for signs of frustration, embarrassment, or withdrawal. And third, help advocate for treatment and referrals. Let me leave you with this. When you see a patient laughing through tears or sobbing when nothing is wrong, pause before you pathologize their emotions. Step back, assess, and consider whether the brain, not the heart, is the source of the signal.